In this video on respiratory pathology, we're going to look at treatment of pulmonary disease, kind of the general biomedical approaches. Again, as we dive into each condition, we'll look at the different treatments in more detail. And also look at some of the basic medications that are commonly used to treat respiratory disorders, including bronchodilators, anti-inflammatories, and antihistamines. So from an integrative perspective, using the approach to respiratory disorders should use the therapeutic order again, kind of looking at the urgency, the presence of red flags, etc., and the severity of a person's disease. So, asthma has different stages of severities, we'll see, for example, and they're going to need different levels of intervention. So just using level 1, level 2 interventions are not adequate for all those patients. We're going to need to actually jump to some of the pharmaceutical measures to help that. So we're going to need to triage to really the appropriate level of care. So on one level, we can treat the branches, which would be symptom management, addressing infection and so forth. And then I think where the level 1, level 2 therapies come in is really treating the root of the problem, which would be maybe underlying neuroendocrine, organ imbalances, things like that. Not a lot to say on level 1 except our usual healthy diet guidelines in terms of healthy diets with very low processed foods, low saturated trans fat, low simple sugars, sodas, sweetened beverages, but very high in vegetable fibers, in fruits, nuts and seeds, essential fatty acids, fish, if a person can tolerate, especially the cold water fish like salmon, and assessing adequate hydration, making sure they're getting proper proportion of macronutrients, proteins, carbs, and so forth. Obviously exercise, good lifestyle with sleep hygiene, alcohol use, smoking recommendations, and then stress reduction. So I'm not going to go too much into that. For level 2 therapies, really for addressing the pulmonary system, there's a couple of classic patterns that we tend to see, and that would be the ones I already discussed in the previous video there, looking at, these damp cold, damp heat. Do we have a liver spleen disharmony, lung qi deficiency, lung yin, spleen qi, kidney and yang, and kidney yin deficiencies? And so then addressing that with the appropriate herbal therapies, micronutrients, acupuncture, and so forth. Not a lot of need for level 3 unless a person needs some sort of hormone replacement therapy like low thyroid. IV nutrient replacement, really, and that's controversial in terms of how beneficial that would be here. I find there's maybe a need for that in some of the malabsorption syndromes and the gastrointestinal disorders like celiac, but in this case, people are usually getting adequate nutrition, and the need for intravenous vitamins is a bit controversial. But level 4 is where we need to be sure we understand when it's appropriate, when we need to refer for those if you're not prescribing those medications yourself. And so the classic medications that typically are used for a lot of chronic respiratory disorders would be bronchodilators, the inhaled bronchodilators, and that would be either the beta-2 agonists. So remember, the beta-2 receptors are the sympathetic adrenergic receptors on the smooth muscle in the airways. When they're stimulated by epi-norepi endogenously, they bronchodilate, but if they've designed medications essentially to do the same thing, and so those would be the SABAs, short-acting beta agonists, and the albuterol is a good example of that. But then LABAs, we'll look at that in detail here in a second. These are longer acting beta agonists. And then anticholinergics, they block the parasympathetic response. Remember, parasympathetics cause bronchoconstriction. And those are not typically used in asthma, but we do see them used more in the COPD, like chronic bronchitis. So that's bronchodilators to open the airways, antimicrobials to treat whatever microbe might be creating a problem if indicated. So that would be antibiotics, oral and intravenous, antivirals, those are usually oral, and then antifungals, and those are going to be more typical in immunocompromised patients that can develop fungal pneumonia and so forth, and so they might need antifungal agents. Corticosteroids are anti-inflammatories, and they can be delivered intranasally for chronic nasal allergies, Flonase, you might have heard of that. Inhaled, that would be more typical for asthma, potentially for bronchitis, chronic bronchitis, and then there's in very severe exacerbations of asthma and so forth, maybe oral steroids, corticosteroids are indicated. Antihistamines, we'll look at those. They can be oral or intranasal. And then typically pain and fever relief would be acetaminophen, the Tylenol, the NSAIDs. Aspirin usually is not indicated because a fair number of people actually have allergic hypersensitivity to asthma, and that can make to aspirin, and that can make everything worse. Other medications that are commonly used, like for asthma, would be what are called leukotriene antagonists. Leukotrienes are like a type of, similar to prostaglandins, they are a inflammatory mediator. They're a little made from fatty acids, but they are overexpressed by the white cells that accumulate in the airways in asthma. And so leukotriene antagonists would block the receptors that they bind to, thereby decreasing inflammation. Mast cell stabilizers. Mast cells, remember, are your immune cells that release histamine. And so a mast cell stabilizer makes it more difficult for the mast cell to release histamine. They release histamine because of IgE antibodies. So you get an antibody to a certain type of pollen, for example. The IgG antibodies lock on. Actually, you need two of them to lock on to the mast cell. When they join together, and when that antigen binds here to this site, that's what tells the cell to release histamine. So the mast cell stabilizers stabilize that to prevent the histamine being dumped out. So there's a class of medications for that. Alpha agonists constrict the blood vessels. Primarily, we're thinking about those in the nose. So if people with lots of nasal discharge, all that fluid is coming from your plasma. That's actually leaky arterioles up in the nasal passages. The body's trying to vent something, but if that becomes excessive, remember alpha-1 receptors are on the little arterioles, and when they're stimulated by the sympathetic nervous system, they cause vasoconstriction. And so alpha agonists can be given to cause vasoconstriction. So phenylephrine, those kinds of drugs, pseudoephedrine, all of those are alpha agonists. And then pulmonary surfactants are given when there's surfactant deficiency, like in the newborns. So this is the kind of overview of the different medication classes and the different levels of the therapeutic order for respiratory disorders. So let's look at a couple of these medications in more detail. So let's look first at the bronchodilators. Again, we can have short and long-acting agents, and the first class would be the beta-2 selective. They're selective to the beta-2 receptors in the airways, beta-2 selective adrenergic agonists. And the short-acting or SABAs would include albuterol, very commonly prescribed, and there's different names for it like Acuneb, ProAir, Proventil, Ventolin. The pyrbuterol and the terbutaline are others. Some of these are used in nebulizer therapy. So when a person goes to the hospital or emergency room, they get nebulized. They're usually putting a SABA in there to open up the airways. And so they're used primarily for asthma, for COPD, or any bronchoconstrictive disorder. They're administered via a metered dose inhaler. Not commonly, you can use tablets, but that's going to have a lot of systemic effects, so we usually prefer these to be inhaled. Rapid onset of action between 5 and 30 minutes, and they can give relief up to 6 hours. And the good thing about being selective beta-2 is they, although it's not perfect, they generally don't stimulate beta-1 receptors, which are on the heart. And so that won't increase heart rate or heart contractivity and so forth. That said, I know plenty of asthma patients who get a rapid heart rate after taking their inhaler, so it's not perfect. But it's actually much better than non-selective agents. I think I mentioned ephedrine, which is in Mahuang, ephedrine. Very good alkaloid, but it stimulates the beta-2 receptors, also stimulates beta-1 receptors on the heart, so beta-2 is on the lungs, and stimulates, unfortunately, alpha-1 receptors, which are on blood vessels, and that would increase blood pressure. And so this is why the FDA has actually taken this off the shelves, because a number of people that didn't know these effects with high blood pressure or cardiac disorders were getting a lot of problems with ephedrine. Now, when ephedrine is combined with other herbs like peony and whatnot in Chinese herbal formulas, we tend to have this, there's some data suggesting some of these effects are mitigated. and you're protected a bit more from just the straight effects of the mahuang and the ephedrine. Within mahuang itself, there are flavonoids also that are anti-inflammatory, so you're getting a synergistic effect there. But if you just take straight ephedrine, it has the effects on all three of these different receptors. Usually the adverse effects are pretty minor, maybe some sympathetic effects like fine tremor, anxiety, some dry mouth, palpitations. Very rarely, again, tachycardia, any arrhythmias, flushing, or severe sleep disturbance. Now, in some patients, especially with more severe chronic asthma, there can be a paradoxical bronchospasm. Can also create urticaria, angioedema, and drop blood pressure, resulting in syncope or fainting, and then circulatory collapse. And then very high doses may cause your potassium levels to go low. These are not common, but I just put them on the list to be thorough. The LABAs, these would be salmeterol or formoterol. These are usually never given alone because they're finding that actually given alone, they can actually increase the risk of sudden asthma death. So what we do is combine the LABAs with a steroid. And I'll talk about that class coming up next, inhaled steroid. And the steroid has an anti-inflammatory effect. The LABA is working long-term to keep the airways open. And so most of their combinations are going to be like Advair, Discus, and so forth. So again, same kind of idea, bronchodilation administered by a meter dose inhaler. In this case, a single dose provides up to 12 hours of bronchodilation, not just 6. Again, not recommended as monotherapy and might increase the risk of sudden asthma death. Okay, so those are important to know about, the difference between SABA and LABA. Then we have the LAMAs, and that would be an anticholinergic, long-acting muscarinic antagonist. So remember, the parasympathetic nervous system secretes acetylcholine, and it binds to muscarinic receptors on the lung tissue and smooth muscle. And when that binds to the M receptor, that causes bronchoconstriction. So the lungs become constricted. And so what this does is it actually blocks that receptor. So this would be ipratropium. This is often given in things like Combivent and so forth. So usually ipratropium in this case with the salbutamol and so forth. These would be the LABAs that they add to that. So that's the anticholinergic. Here, this is going to be used primarily for COPD, chronic obstructive pulmonary disease, and especially chronic bronchitis. Less commonly for asthma. It's kind of, these are derivatives actually of atropine. Atropine has a more general effect, but this is inhaled, so it's not going to have the more systemic effects that atropine has. Usually the effects are what we call anticholinergic effects, and that would be dry mouth, sedation, skin flushing, rapid heart rates, nausea, and it can worsen glaucoma in patients that have that. And people should use caution with anyone with peanut allergies with this one. So those are some of the two big classes of bronchodilators. Other agents that are less commonly used would be theophylline. This used to be a major treatment for asthma. This is an ingredient in green tea, or any tea, black tea as well. It's what's called a methylxanthine. It's related to caffeine, well absorbed orally. And it is a non-selective, what's called phosphodiesterase inhibitor. It inhibits cytokines, TNF-alpha, leukotrienes. It also is a adenosine receptor blocker, and that's going to increase heart rate, increase strength. But it has an effect of opening airways as well. So used to be used, again, very commonly for asthma, but because it has all these other adverse effects, kind of like caffeine times 10, it has been associated with seizures and fatal arrhythmias, so we don't tend to use theophylline. I have seen a couple patients on it that are very unresponsive to the other medicines, so it's kind of one of these tertiary agents that physicians have in their black bag if they need it. Ephedrine, this is a bronchodilator. Again, this is the alkaloid from mahuang, from Ephedra senecio. This again is no longer used as primary treatment because of all the adverse effects. This one also crosses the blood-brain barrier, so it can have effects on the central nervous system, not just the peripheral nervous system. Okay, so those are bronchodilators. Now, in terms of anti-inflammatories, the glucocorticoids are probably the mainstay of anti-inflammatories for pulmonary conditions. And the ones that are most preferred are the inhaled glucocorticoids. And that's because when you take these systemically, although they're much more powerful that way, they have a lot more adverse effects. So we'll talk about that here in a minute. But basically, the inhaled ones would be things like the beclomethasone, budesonide, fluticasone, and so forth. Again, they can be combined with LABAs like an Advair, which is the fluticasone with salmeterol, or Symbicort, which is the budesonide with formoterol. So what they do is they actually block phospholipase A2. This is an enzyme in your cell membranes. When there is any inflammation in a cell or around a cell, this enzyme becomes active. It cleaves off fatty acids in your cell membranes, and those go on to make pro-inflammatory eicosanoids like the prostaglandins and leukotrienes. Basically what these glucocorticoids do is they inhibit that. They also decrease the number of white blood cells like eosinophils and macrophages and T cells that have accumulated in the airways in, let's say, asthma. They reverse any mucosal edema and decrease the local capillary permeability. And over long term, they reverse the kind of hyper-responsiveness of the airways. So what we're finding is that the bronchodilators alone, especially for moderate to severe asthma, are not adequate. In fact, patients who are taking their inhaler more than twice a day are not well controlled. And that means they usually have this systemic inflammatory, this process of inflammation in their airways, making them very hypersensitive. And they're actually at much higher risk of sudden asthma death, especially over the years. So this is why the current standard is to add in a inhaled glucocorticoid together with the bronchodilator for the moderate to severe asthma. These are given by metered dose inhalers, often with a spacer. The spacer helps for better diffusion of the powder. The oral steroids might be needed for severe episodes, so prednisone might be given for very severe episodes of asthma, usually short term at a very high dose. Remember again, with steroids, an important rule of thumb there is if a person's been on it for more than 5-6 days, let's say 60 milligrams or higher of prednisone, they cannot just stop that drug abruptly. They have to actually taper it. Otherwise, they can go into a fatal adrenal collapse. So this is something that we have to be careful about. You know, patients are like, I don't want to take my prednisone anymore. They've been on it for more than a week. They have to taper it. And now that's not going to be the case so much if they're on like a 5 milligram dose, very small dose. But there's larger dosages for sure, they're going to need to be tapered. And so the doctor will need to write them a taper schedule to get off that. That's for the oral steroids. That's not going to apply here to the inhaled glucocorticoids. These are the drugs of choice for persistent asthma. So again, we'll look at the asthma guidelines in a bit. They have to be taken continuously to prevent that inflammation. The adverse effects are fairly uncommon at the usual dose, but it might include sore throat, sore mouth, hoarseness, cough. Thrush is possible because the glucocorticoids inhibit the innate immunity in the mouth, and so candidal overgrowth can occur. So thrush is a possibility from these inhaled glucocorticoids. Children, we do have evidence, unfortunately, that they do get absorbed systemically. For a while it was thought they didn't, but now there's evidence out there that they do, and that can actually cause the same effects as oral steroids, although at a much lower dose, and that would be things like delayed growth, decreased bone thickness. So one of the things that chronic corticosteroid use does is it can thin your bones. Cataracts and glaucoma at high doses are also potential adverse effects from the inhaled glucocorticoids. For the most part, though, they're considered safe, necessary medications. I can tell you the compliance on these is pretty low, and so this is a big challenge as people sticking to their regimens. But I'll say more about that in the asthma section. There's another possibility, and that is nasal corticosteroids, nasal sprays. So that would be things like the beclomethasone, but probably the most common one would be the fluticasone, and that's Flonase. So Becanase, Flonase, Rhinocort, all of these. Again, anti-inflammatory, same effects, but they're working more just locally in the nasal passages to decrease the inflammation from allergies. So allergic rhinitis. The systemic effects are even less than the inhaled glucocorticoids for asthma. They're more effective than antihistamines in relieving nasal symptoms of rhinitis. So people that are on chronic antihistamines, when they switch to this, they have to take it a lot less frequently. Usually it takes a couple of weeks for the improvement to be noticed. One fairly common thing I've seen people taking Flonase over time, for example, is they get more nosebleeds. You can also get nasal candidiasis. So again, that's from direct immune suppression there. So that's the nasal corticosteroids. Leukotriene antagonists, or leucasts, that would include things like montelukast singulaire. That's probably the one that is most commonly used. This inhibits the enzyme 5-lipoxygenase, which is so when phospholipase A2 breaks off those fatty acids, it's 5-LO together with COX. Those are the two enzymes, and there's a COX-1 and a COX-2. These enzymes will make your prostaglandins and leukotrienes. And leukotrienes, we know, are extremely bronchoconstrictive. They create a lot more airway hyperreactivity and so forth. So these are oral drugs. They're taken to downregulate leukotrienes. Very rarely you can get a vasculitis from these drugs, but that's usually at a higher dose. So that's going to be very rare. So that's leucasts. Now what's interesting, I'll just say in terms of natural products, we actually know that boswellia, frankincense, the resins in there, actually the sesquiterpenes can actually also act as leukotriene antagonists. So we're finding studies in both asthma together with, there's interestingly another condition where we get a lot of leukotrienes, and that is actually in the inflammatory bowel disorders, especially ulcerative colitis. So another interesting lung, large intestine connection there. But that would be frankincense kind of is something there. So a lot of times in the herbal formulations I've given for asthma, that's something I consider. And then finally there are mast cell stabilizers, cromolyn, which interestingly comes from a natural product. It comes from an herb called Kella, which is a member of the carrot family. In Chinese medicine, a lot of carrot family herbs like Baijiu, the Angelica daharica, and so forth. These are all used to treat what we call wind cold conditions, and many of them actually are bronchodilators. Well, one of the interesting things about the Kella is that it contains a compound which, when researchers looked at it, it's been an herb. It grows in North Africa. It was used in Egyptian herbal medicine for centuries, millennia, and for asthma and different respiratory conditions. And when researchers in the 60s began to look at this, they found the compound in their Kellen actually was a very potent mast cell stabilizer, and so they made it into a prescription medication, and that's cromolyn. This is anti-inflammatory. Again, this is usually used as an adjunct agent in addition to the bronchodilator and the steroid. If a patient needs even additional control, they might be given the leucast or a mast cell stabilizer. Okay, so that's kind of the overview of some of the more commonly used medications there for asthma, COPD, and so forth. One final class of medications would be the antihistamines. And I'll just say a little bit about these because so many people use them, and it's important to know what things might interact with them. Antihistamines block the H1 receptor, so that's the receptor on tissues and so forth that when histamine's released, it has many different effects. One is to cause vasodilation, so blood vessels become more leaky. It tends to attract in more white cells and so forth, creates local edema. So the antihistamines block the receptor to histamine to prevent that from happening. Now, interestingly, there is a class of medications called H2 blockers. The histamine 2 receptor And that is actually found in your stomach, in your parietal cells, which secrete stomach acid. And those are used for as acid blocking agents. That's a different class. So we're going to talk about the H1 blockers. Now, H1 receptors are also interestingly located in the brain, in the central nervous system, in the areas that maintain wakefulness and alertness. So if you block the H1 receptors, you get drowsiness. And that's unfortunately one of the major side effects of this class of medication. Now, there's 3 generations. The first generation would include the diphenhydramine, which is Benadryl. The chlorphenhydramine and so forth were all part of that as well. And then there's a second generation, loratadine, that's Claritin, cetirizine, that's Zyrtec, and the terfenadine, Seldane. And then even a third generation, and that's the fexofenadine, Allegra, and the desloratadine, which is Clarinex. Now, why do we have these different generations? Well, it turns out the first generation has a lot more of these systemic effects. So they all block the histamine receptors, and so they're used for all sorts of allergic disorders like allergic conjunctivitis and urticaria, angioedema, atopic dermatitis, or eczema. They're in a lot of the over-the-counter cold products, although there's little efficacy that they work well for that. And they can be given orally, they can be given topical, and so forth. The first generation, in addition to the antihistamine effects, are also very strongly anticholinergic. They block a lot of the parasympathetic activity, so that sometimes they can actually make you too sympathetic, so speed up your heart rate, dry up your secretions. Unfortunately, that can even constrict your airways a little bit more. They have an alpha adrenergic effect, which is to constrict blood vessels in the nose again to prevent all that nasal leakage. And then they have effects on serotonin receptors. So we say they're very non-selective, and they have a lot more then of adverse effects than we'll see the other agents have here. They have both peripheral and central nervous system effects via those H1 receptors, so a lot of drowsiness. Sedation's a huge thing of this, and that's why some people take the Benadryl as a sleep agent. I will say that is not indicated whatsoever, and we have very clear kind of medical advice on that. That's long-term been associated with a real deterioration in sleep function and cognition and everything else. Also used to treat like nausea, vomiting, especially from like motion sickness or diarrhea. So first generation has a lot of different applications. Benadryl is still widely used, but it does have that very strong sedating effect. Second generation is going to be more selective for the peripheral nervous system versus the central nervous system. More selective for those H1 receptors peripherally. And there's going to be less drug reactions, less sedation. And the third generations, these are actually active in enantiomers or metabolites of that second generation, and they have even fewer adverse effects. So a lot less sedation in the Allegra and the Clarinex versus Benadryl. Again, all of them have some degree of sedation, maybe dizziness, tinnitus, blurred vision, anxiety, and so forth. Nausea, vomiting, all your anticholinergic symptoms, again, more prominent in that first generation. Rarely, one anticholinergic symptom could be urinary retention, because you actually need your parasympathetic nervous system to stimulate, to allow urination to occur, and to contract the muscle in the bladder that squeezes the urine out. So if you block that, you might get urinary retention, again, palpitations, very low blood pressure, even hallucinations and psychosis have been reported with Benadryl. So that's just something to know about there, but again, these are very commonly used agents. I mentioned the alpha blockers or alpha agonists, and these stimulate the alpha-1 receptors, and it's going to do that in all of your arterioles, but especially in the nose, that's going to cause vasoconstriction. So these are technically nasal decongestants, and they're for short-term use only. Some of the studies that have actually looked at these versus placebo have found really little effect, so I do not recommend alpha blockers, but alpha agonists, but a lot of people want them, and so it's that would be Sudafed, Afrin, Zicam, things like that. Phenylephrine is a variant of pseudoephedrine, but it can't be made into methamphetamine, so that's why this one's over the counter. The pseudoephedrine now you have to get with a prescription. It's behind the counter because that can be actually made into methamphetamine, and there's a big market for doing that. But these are usually combined with antihistamines for greater effect. One of the biggest problems they have here is what's called rebound nasal congestion. So you use it for longer term and you actually get a worsening of the nasal congestion because of that. So they can be an aerosol form or oral. The aerosol form has fewer adverse effects, but another big effect, especially the oral, is going to be hypertension. Because in patients with hypertension, you stimulate their alpha-1 receptors. That's going to cause further vasoconstriction throughout the body, raises the blood pressure further. So you probably heard commercials that say, is that over-the-counter cold medicine safe for your blood pressure? Well, they're saying that basically if the over-the-counter cold medicine has these compounds in it, it's not safe for blood pressure. So that's something to know. But pretty much I don't think these really are great agents whatsoever, and we have much better herbal alternatives for these, and for a lot of these actually. Anyway, so that's an overview of the basic pharmacology that we'll be seeing as we go through the respiratory tract disorders.